Thank you all for coming and spending part of your evening with me. I really appreciate it. It's my first time to Hong Kong. I've been to India many times and to mainland China many times, but I've never been here, and what a beautiful place this is. It's just really remarkable. It's spectacular. Before I start, I just have a quick question for you because I didn't know what the makeup of the audience would be, and it might help me to target my discussions a little bit. So can I have a show of hands? How many of you are medical? And how many are non-medical? Okay, so it's about half and half. All right, good. Well, what I want to talk to you about tonight is a problem that's near and dear to my heart, which is doctors making the wrong diagnosis. And I titled this A Paradox and a Calamity because, as I'll try to convince you, it is a calamity. It's a major problem. And it's also a paradox because if you think about all the technologies that we have, it's remarkable with the machinery that we have that we still have a problem diagnosing patients accurately. And the subline I put for this was actually we have to align our educational technologies, that is how we help doctors to think, with all of the other modern technologies that we have. So let's talk about that. So I want to tell you first about a woman named Jane. This is a true story. She showed up to a very famous East Coast hospital. She was 67 years old, and she went to the emergency room saying she was dizzy and having vomiting. She was seen multiple times and diagnosed with gastroenteritis. And on the fourth visit or so, after multiple visits, somebody said, let me think about this differently, and did a CT scan and revealed that she had a cerebellar stroke. Unfortunately for Jane, this was too late. Hours later, she fell into a coma and died because those of you that aren't medical, the cerebellum's in the back of the brain. It's a very tight space. And if it swells, the brain can push through the hole in the head and people herniate and die. And that's what happened to Jane. Now, you might think that's awful, and it is awful. And then you might think, well, that can't be very common at good places with good doctors. And the fact of the matter is that clinicians are often wrong. Don't take my word for this. In 2015, the Institute of Medicine, which is a very erudite body in the United States, decided to evaluate diagnosis in healthcare. And what they concluded was the diagnostic errors were a significant contributor to patient harm and have received too little attention till now. They went on to estimate that 12 million people a year in the United States are misdiagnosed. And don't think this is just a US problem. This is a worldwide problem. It's so common that virtually every American is misdiagnosed. As a matter of fact, I had the disadvantage of being admitted myself to the hospital several years ago and having the doctors tell me it was X and having me look at them and say, no, you're wrong about that actually, which I'm in a better position to do than others, but it still happens even to doctors. Trouble is sometimes there's devastating consequences. Some people have estimated that the cost of that could be as high as hundreds of billions of dollars a year. So we do really have a calamity at our doorstep. But what if a pedagogical program that could decrease diagnostic error by 30%? And what if that meant for every 3 students we taught, we could decrease diagnostic error by 1 person? That would be great. I mean, per 3 people that they see. I'm here to tell you that I think we have that. And what I want to do is tell you about this so we can move forward. But before I tell you what the solution is, I have to tell you what the problem is and why it's there. So why are doctors so bad at this? Right? I'm a doctor. I'm telling you, it's not good, right? There's lots of reasons. I'm going to go through some of them with you. The first reason is what doctors do is difficult. So I'll see a patient. I'll see many patients in a day. Each of them have a symptom. So imagine one patient has dizziness. Well, here's the list of things that cause dizziness. You're not meant to read this. I know this is a horrible slide. I get that, right? The idea is that a doctor in a very short period of time, minutes, maybe 10 minutes if you're lucky, has to figure out which of those 50 things it is. And this is just one symptom he's going to see that day in one patient. And then he or she is going to go on to other patients and have to figure out what's wrong with them. That's not a simple task. Secondly, I teach and have taught for 25 years. And I'm going to tell you the educational system of doctors is fundamentally flawed for a lot of reasons. First of all, in medical school, the medical education system primarily focuses on diseases rather than symptoms. Now, I have taught and continue to teach at the University of Chicago for 17 years a course on disease. That course meets for 3 days a week, 8 hours a day for 4 months. I believe in teaching about diseases. That's not the point. Doctors have to know about disease because it's the foundation of everything that they know. But what we don't do well is we don't go on to describe carefully how they should evaluate patients with symptoms. So in many medical schools, doctors will get a lot of information about pulmonary embolism or pneumonia or heart failure or emphysema. But what they're not given is a lot of information about the patient is short of breath, and how do you figure out which one of those that patient has? That's left for them to kind of figure out. Well, that's not very smart. Another problem is faculty model System 1 thinking. And what do I mean by that? So System 1 thinking is what some people refer to as fast thinking. It's pattern recognition. It's what you use when a fancy car drives by and you know immediately what that fancy car is. You don't think about it, you just know what it is. And as a matter of fact, if I asked you, how do you know that was a Porsche? You'd say, it looks like a Porsche. Well, that's not very helpful to the learner. It looks like a Porsche. Okay, well, can you tell me more about that? And you might not be able to do that because things that you know well are often very hard to articulate. Here's the problem. Who's teaching our medical students? They're old folks like me. I've been doing this for a long time. I can tell you when someone walks in often what they have right away because it's simple, but that doesn't mean I can describe it well. So the advantages of this system are that it's fast, and when you know it, it doesn't cause much cognitive load. The disadvantages is it fails if you've never seen that before. So if the doctors haven't seen that disease before, that pattern System 1 thinking doesn't work. It also fails if patients have unusual presentations of that disease. So those of you that are not medical may not appreciate that diseases don't always present the same way. That one disease can present 10 different ways. Here's the trouble with medical education. I'm about to teach, I start in November, I'm about to teach my students over 300 diseases. If each one of those presents in 5 different ways, and I have to tell my students about 1,500 presentations, their brains are going to explode. So what do? I teach them classic presentations, but that means that they often miss the non-classical presentations. System 1 thinking is also prone to bias. Last week I saw a case of this. This must be another case of this. And finally, it requires years of experience. So it's great for me, and it's not so great for my students. System 2 thinking is the slower type of thinking that people use mental constructs to consciously solve problems. It is a bigger cognitive load. It's not straightforward. You actually have to think. It's exceptionally helpful, though, when System 1 has failed. But it's rarely taught. Again, why is it rarely taught? Because the people who are teaching them are older and usually know this automatically in their head, and they can't even often articulate exactly what it is, nor do they have time to articulate exactly how they're thinking. Although the optimal approach would be to teach them both, right? Another problem with our medical education system is we don't teach our students and residents well enough how to both order tests and interpret the tests. And I want to give you an example of this to bring this home. So I recently saw, the common misconception is that if the test is positive, the patient definitely has that disease. And if the test is negative, they definitely don't have disease. That's the error. And I want to give you an example of that error. So recently I was in my clinic and I saw a man who was about my age actually, and he had high blood pressure and high cholesterol and he had a bit of diabetes, so he had every risk factor for heart disease. And then he tells me that when he walks up a hill, he gets pressure in his chest. Well, that's a very classical presentation of angina, of heart disease, of blockages in the artery, so that when he's walking, they can't deliver enough blood and people get pain. It's so classical with all those risk factors that if you looked at the statistics, 90% of patients like that actually have heart disease and blockages. So I sent him for a stress test. That's a test that's often done to evaluate how severe it is, and the stress test was normal. Well, I know enough at my stage to say, wait a minute, maybe the test is wrong. And I send him on to a cardiologist, and the cardiologist sees him and says, well, the stress test looks okay. I think we're all right. And I called him up and I said, I don't think so. If you actually do the arithmetic, and you can do it in these situations, and take into account the accuracy of the test with how likely the disease was, it actually is statistically more likely that a man like that still has cardiac disease than that he doesn't have cardiac disease. So he asked me, what do you want me to do? And I said, you should do an angiogram. And he did the angiogram, and the blockages were so bad, he almost went from the angiogram to bypass. He ended up getting a few stents, but they weren't even sure they could stent him. That's how bad his disease is. And this was a faculty member in cardiology. So I'm not talking about junior student. I'm not talking about an intern. I'm not talking about resident. This is a big problem. Another problem is doctors are busy. And so all of us rounding have lots of patients to see, right? And so if I have a lot of patients to see, I'm supposed to be teaching at the same time. Well, if there's too much clinical work to do, my first priority, all of you that are non-doctors will be glad to know my first priority is to you, right? My second priority is to teach my students, but I can't let my patients not be cared for. So sometimes there's not even enough time to teach this properly. What the doctors see is random. So when I have students on my service, I can't call up the community and say, look, I need a heart failure patient, I need a pulmonary embolism patient, I need an emphysema patient, and I need a pneumonia patient. Who do my students see? They see the people that were admitted. So the diagnostic opportunities are random and they're often insufficient. So those are some of the problems with our educational approach. I'll also tell you that our evaluation system is flawed, and this is a big problem. So what do I mean by that? Most of the way that students are evaluated is with multiple choice questions. Those are great at testing facts and not great on testing thinking. Here's the problem. All of our medical students are smart. Here, India, United States, they've learned how to succeed. How do you succeed? You succeed by knowing how you're being evaluated and focusing on how you're being evaluated so you can do well on that. So if they know, and they do know, trust me, right, that the way they're being evaluated is with fact tests on facts, what are they going to study? Facts, right? And they will do this over and over again. Secondly, the feedback they get from faculty is inconsistent. And the next thing I'm going to show you is going to really scare the non-doctors in the crowd, so I apologize for this, but it's true. Advancement is not based on competency. So what do I mean by that? If I was in control of all the medical systems, I would say that you can't graduate until you've proven to me that you're competent in all the things the doctors see all the time. You have to be competent in evaluating chest pain, and you have to be competent at evaluating headache, and you have to be competent at evaluating abdominal pain. You're going to see all of these things and more all the time, and you shouldn't graduate until you've proven that you're competent. That's not what happens. What happens is they take a test, and if they get 70% of it, they graduate. What about the other 30%? Okay, you don't know chest pain. That's not a problem, except for the patient who sees you who has chest pain. This would be like flying in a plane with a pilot who knows 80% of how to manage the flight. He knows how to take off, he knows how to fly, but he failed the landing part. That's okay, we passed him anyway. Do you want to get on that plane? I don't think so. This is seriously a problem. We are graduating people. I will tell you this is true all over the world. No dean of any medical school knows that all of their students who are graduating are competent to manage all the problems that they're going to see. It doesn't happen. So what's the outcome of all of this? The outcome of all of this is we have very smart students. These are very smart people who are trying very hard, but often their mind is a bit of a mess, right? You'd like to see that it's this. That's where I'd like them to get to, but I think what we often have is that. So here's the question. How do we get them to this? So we've done research on this over the last 20 years. So starting in 2002 till now, I and several of my colleagues have been doing research on this that has resulted in 4 editions of this textbook, Symptom to Diagnosis. And what we did that was different is we said, let's study how we can evaluate patients with symptoms in a specific, systematic way so that we could teach that well. And the methodology that we used to study this is we took over 300 diseases that commonly affected adults. And then we went to the medical literature and said, let's find out how accurate is the history, how accurate is the physical, how accurate are the labs, and how accurate are the x-rays for all of these diseases. We probably went through over 5,000 to 10,000 papers between the 3 or 4 of us in order to put this together. We looked at reviews and guidelines, and then we put all that together, and we developed these data-based algorithms that were not meant for IBM Watson, but that were simplified enough that I could tell a resident or a student, and they could incorporate it in their heads and use it when they're seeing patients. And we've published this multiple times. I'm happy to say the new one's coming out soon, and I'm done working on it for the time being. Okay. We had 4 key observations I'll share with you. The first observation is that for almost every single problem, remember we said dizziness is a problem, abdominal pain is a problem, etc. There are key questions that we've termed pivotal that help to organize that big list of things. I'm going to keep using the term differential diagnosis. Differential diagnosis means the list of possibilities to explain the complaint. So there are key pivotal questions that could organize that list of possibilities into clinically distinct subsets. And those clinically distinct subsets, then you could narrow that differential diagnosis and focus on the few things that were left. Wouldn't you rather be able to focus on 5 or 10 things instead of the 50 that's the initial cause? So a classic example that's relatively straightforward is imagine you have a patient with abdominal pain. There's a lot of possibilities, but a very simple question that is an abdominal pain that virtually all clinicians know is you ask the patient, where's the pain? Because it turns out the causes of pain in the right part of the abdomen, the right upper quadrant, is different than the causes of pain in the left lower part of the abdomen because the organs there are different. That's an easy one. But for almost every symptom, there are key pivotal questions, and many times doctors don't learn these, they're not emphasized, and they don't organize their differential diagnosis in a thoughtful way. Our second observation was that once we narrowed the differential diagnosis down, once we created a much smaller list, we could teach them about how to evaluate that smaller list by teaching them that for each of the diseases left, they should look to see if the patients have risk factors for those diseases, if they have other symptoms of those diseases, or signs. Signs, for those of you that are not medical, are things that you find on examination. Symptoms are things that patients complain of, right? So I can teach them, if they have a shorter list, to look for risk factors of each of those diseases on that list. Now here's what's really interesting about this, having taught students for 25 years. They know this, they just don't know how to use it. So if I ask any of my students who are very bright, what are the risk factors for a patient having a blood clot in the lung? A blood clot in the lung, the medical term is a pulmonary embolism. They know that. They'll tell me, well, look, the risk factors for a blood clot in the lung are being immobilized, because when you're immobilized, you get a blood clot in the leg, and it breaks off and goes to your lung. Or having orthopedic surgery, or having cancer, or having a family history of blood clots. They know that. But now they see a patient who's short of breath. And now they know on that list is pulmonary embolism. They're not good at all at saying, let me think for a minute. Now the risk factors for this are this, X, Y, and Z. Let me ask the patient whether they have those risk factors, because if they do, it makes it more likely than if they don't. They don't have that organizational schema in their head, and we can teach them that. So I want to tell you about a new paradigm, but let's start with the old paradigm. The old paradigm has been referred to as the hunt and peck approach, but let's start. So the first thing that doctors ask patients to do, and we still do this and we should, is ask a patient to describe what's going on, right? That makes sense. Hopefully when you've seen doctors, they've asked this. And we see if we recognize that pattern. And if we do, that's great. And we also think about must not miss hypotheses. Must not miss hypotheses are things that if you miss, the patient dies. That's why they're must not miss, right? Life-threatening possibilities. And for almost every complaint, there are some thoughts that go through your head that are very serious. As a matter of fact, my wife and my family has learned never to ask Dad about what's going on, because the list in my head is always horrible. So they don't ask me that. Once they've done this, then they can say, okay, I've got some ideas, let me test and interpret those. And if they can make the diagnosis, that's great, and they're done. And actually, in the new paradigm, that's the same. But what happens when they don't recognize it, which often happens? Then there's this laundry list of possibilities, and they say, well, I don't know what it is. Maybe it's A and C. Okay, if it's not that, maybe it's E. No, it's not that. I know what it is. It's H or I. They have no idea. There's this random set of possibilities that they evaluate. And you should be on the wards with me. Sometimes what I'm hearing is unbelievable. Now, we can do this better. So a paradigm that I would present to you is the first step, first phase, is very similar to the old phase, right? See if you can get the data, see if you can recognize the pattern, see if there's any must not miss hypotheses, and evaluate those. But what if you don't find the answer? Then instead of going to this hunt and peck approach, you should use these pivotal concepts that we were just talking about. And using those, you should limit that differential diagnosis. Find out what bucket or what subgroup you're in so you can focus on 5 things instead of 50. And once you've done that, explore that limited differential, looking for those risk factors, symptoms, and signs so that you can be accurate and all the questions that you ask are in the right line instead of being all over the place. Let me give you an example. So if you think about somebody who's lost consciousness, there's a long list of possibilities. Those of you that are not medical will be happy to know I'm not going to describe each one of these to you. Although afterwards, if you're interested, we can sit down, right? So that's a long list, though. When you see a doctor, if he doesn't have any idea how to do this, that's a lot of things to go down. So how would we organize that? Can we use pivotal points to focus that differential? And we can. And it turns out for loss of consciousness, there's two issues. The first one is some people who have lost consciousness have lost it because they have syncope, which is due to low blood flow to the brain. If you don't have enough blood flow to the brain, you're going to pass out. Some people who have lost consciousness have lost consciousness because of other problems. Their blood sugar was too low. They were intoxicated. They had a massive stroke in their brain. And so the first step is to separate one list from the other list. In people who've had syncope, we can then figure out what type of syncope they've had. So let me show you this in a diagram. So what we end up with is transient loss of consciousness where we started, but now there's 4 distinct groups. And you might say, I don't really understand why this is valuable. The reason it's valuable is each one of those has its own smaller list. And let me ask you a question. Wouldn't you rather that your doctor or you could focus on one of these subsets or the other subset instead of having to handle the whole list? Because when they're handling the whole list, I'll tell you they're doing it poorly. There's too much information. They don't know what to test for. They don't know what to do. They don't know what to ask you. The third observation, which was actually surprising, one time when I was on a trip and away from home, I decided to take all the data from the book and put it into an Excel spreadsheet. You have to be pretty bored to want to do that. And what I found was, when you looked at the history and the physical exam, that many of the findings were often not present in patients who had that disease. And we call that insensitive. It's not sensitive. If it was sensitive, they would be there. And what we found is they're often not sensitive. Now, the trouble is that the medical curriculum, like the course I run, teaches the classic presentation, because I already told you I don't want their heads to explode because I tell them every possible variation of a disease. Now students go ahead and memorize that classic presentation because they're going to be tested. And the trouble is patients don't read that book. If they read that book, that would be great. Actually, I had a funny story once where a lady came in and she said, I don't know what's wrong with me. I'm having diarrhea. I'm hot all the time. You know, I'm losing weight. My hair is falling out. I have all these symptoms. I have no idea. I said, I know exactly what you have because that's a classic presentation of hyperthyroidism. But I don't see that very often. So students and residents exclude these hypotheses from consideration because it doesn't look like what they expect, and they make diagnostic errors. This table kind of summarized all that data I just showed you. So what this is getting at is how sensitive were 337 findings in 101 different diseases. And what you can see here is the different levels of sensitivity. So how many of the findings, when people have the disease, are there in 91 to 100% of people who have that disease? And only 10% of the findings are present in 90% of the people that have that disease. Another 10% of findings are there in 80 to 90% of people who have the disease. And that means in aggregate, if you looked at all these classical findings, only 20% of them are there in 80% of patients who have the disease, which means that the other 80% of findings are often not there. So a student goes looking for the finding, they don't find the finding, and they say the patient doesn't have the disease. I'll give you some examples. Maybe that will be helpful. So if we remember I mentioned pulmonary embolism, that's a blood clot in the lung. So it's not surprising if you have a blood clot in the lung that you'd expect the patient to be short of breath. That's what dyspnea is. And you'd expect, because the blood clot gets to the lung suddenly, that would occur suddenly. And you might expect they'd have chest pain, and you might expect that their heart rate would be too fast. That's what tachycardia is. Half of medical school is learning these words for those of you that aren't medical, right? And so that's what you would expect. And the question is, how often do you see it? So here's how often you see it. So if you look at patients who have proven pulmonary embolism, 59 to 85% of them are short of breath. Well, if you do the arithmetic, that means 15 to 41% of people with proven pulmonary embolism don't have shortness of breath. That's shocking. And a resident might be tempted to say to me, look, this patient has chest pain, but I'm sure it's not from a pulmonary embolism because they're not even short of breath. Everybody knows patients with pulmonary embolism are short of breath. Everybody but the patients, because 15 to 41% of them are not short of breath. A rapid heart rate in different studies has been found in 24 to 70% of people who have proven pulmonary embolism. So roughly half, which means the other half don't. Let me give you a different example. Think about appendicitis. So you'll be happy to know, my patients are happy to know, that I never operate on anybody. That would be a disaster. Never put a knife in my hand. It would be horrible. So what that means is when I see a patient who I think has an appendicitis, I call my surgical colleagues. And that means they often send the resident first to see the patient. And the resident's very nice and very polite, and they'll say to me, Dr. Stern, thank you for calling us, but I think it's very unlikely your patient has an appendicitis. They don't even have a fever. Well, here's the problem with that. If you look at people who have proven appendicitis, 15 to 67% of them have fever, which means in different studies, anywhere from 33% to 85% of patients who have proven appendicitis didn't have a fever. And they're telling me I shouldn't think about appendicitis because there's no fever. That's crazy. The likelihood ratio is how it affects your thinking, and I won't go into the statistics of that very much, but it's 1, which means that whether or not fever is present doesn't affect the likelihood of appendicitis a bit. The last observation I'll share with you is that although the physical exam is insensitive and findings that we expect are often not there, when they're there, they're often very specific. Over 40% of the abnormalities in the literature were over 90% specific, which tells us that certain findings are very specific and worth looking for. So we have to tell our students to look, because if you find it, it's helpful. Here's an example. If you look at patients who have heart failure, 2 findings that are often seen are, 1 is jugular venous ascension. That's where your neck veins are bulging because the heart can't pump, so the blood backs up and the neck veins are bulging out, right? And the other one is an S3 gallop. That's a sound you hear with your stethoscope when you listen. Bum, 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 bum. It sounds like a horse galloping. That's why it's called a gallop. And so these findings are, again, often not present, but when they are, they're incredibly specific. So much so that if a patient had an S3 gallop, it's 60 times more likely that they have heart failure than another disease. So what do I tell my students and my residents? What I tell my students is that the absence of signs virtually never rules out a diagnosis, that the presence of signs can help you to rule in a diagnosis, and the real take-home message is this. You have to pay attention to what you find, not what is missing. And what I will tell you they tell me all the time is the opposite. They tell me all the things they didn't find as though it should convince them not to look for that disease. As a matter of fact, I make a joke with them. I tell them that every time you're tempted to say to me that patient X doesn't have disease Y because they don't have this finding, I say, take your hand and put it over your mouth. Stop talking, because you're wrong when you say that. All right. So you've been listening for a while now, and some of you are probably wondering, yeah, okay, does any of this make any difference? And I want to tell you about a study we did, because I think it does make a difference. So we've just completed a multi-center study in the United States of 8 medical schools where we randomized students to this training or not. And we evaluated the impact of how well they would be accurate diagnosing another simulated case. And we trained them with computer-based avatars and with these symptom to diagnosis lectures that we've made. And here's what we found. So we trained them on one of the symptoms was abdominal pain. And what you can see is at baseline, 35% of the students had the wrong diagnosis. These are students 1 year from graduation. They've already been trained on all the diseases, and this is how they're doing it. 8 medical schools. These are very well-known medical schools, including my own. Then we would train them on these approaches, and what you can see is the train group, in 1 day, the error rate, the final incorrect diagnosis went from 35% to 8%. And let me tell you that these simulations should not simply guess what the right diagnosis is. It allows them to make a list. It allows them to make tests. It allows them to go back and try again and again. And still at baseline, 35% of them were wrong, and we could correct it to 8%. That's a 27% reduction in error with 1 day in training. We looked at another symptom, syncope. Now, it turns out that passing out is more complicated than abdominal pain. Many of you who are not medical in the audience know something about abdominal pain already. I bet you've heard of ulcers. I bet you've heard of gallstones. I bet you've heard of appendicitis. But I bet you've heard almost nothing about people who've passed out. So at baseline, the students were wrong 83% of the time. They had the wrong diagnosis at the end of the simulation. After 1 day, it went to 50%. And you should say, well, that's still not great, but it was 1 day. It's still a 30% reduction in error. And what this still means is at the end of the day, this is number of students needed to train to prevent one final diagnosis that was wrong. At the end of the day, by training roughly three students, we could decrease 1 wrong diagnosis for those symptoms. That's powerful. And remember I said at the very beginning, if we could reduce diagnostic error by 30% with a pedagogical approach, that would be powerful. So we have a vision for the future that I want to share with you. We've been funded by the Marcus Foundation and is working with the University of Chicago to create a diagnostic reasoning program. The platform is under development, and what it's going to do is develop globally available educational technologies. We're going to optimize the lessons we've learned over the last 17 years and make these globally available to medical students, to nurse practitioners, and other healthcare providers who care for patients. And here's an important part. It's meant to be free. This is not a commercial enterprise, but we rather want to train as many people as we can to make them as good as possible. The vision for this portal is the following. Imagine a website where students can go. What I'm going to do is give you a brief summary of this and then a bit more details. where they could go and get all this information, whether it's the text or new learning exercises or podcasts or lectures or mobile apps. All of this is going onto the website. We're building all of it now. But let me tell you a bit more about each of the tools. So we do have a new textbook. It will come out in December. We are creating adaptive learning exercises that will teach these approaches. So we have mock-ups for this. We're using instructional designers to help us design this because while I can think about medicine, you don't want me drawing artwork. It would be horrible. And we want this to look professional, to engage students who are used to really professionally looking high-end technologies. So the problem with the technologies that are already out there, the simulations that are already there, is most of them that gives the learner the history and the physical already. So if you were to look at most of the medical simulations that doctors are trained on, the whole history and physical is there. That would be like a patient coming in and saying, this all started 4 days ago, and they know exactly what information to tell the doctor. But patients don't know that. That's the information we have to train doctors to obtain. But the simulations give that to the doctors automatically. So it's useful for pattern recognition, but it fails to train doctors to obtain the relevant information. I have to train them. If those pivotal concepts are important, I have to train them about what they are, and they have to learn to then ask the patient that in a clinical encounter. So our approach is going to be to have, we're going to start with 15 symptoms in internal medicine, common symptoms that patients have often, abdominal pain, chest pain, etc., and do at least 5 cases each, so we'll probably have close to 100 simulated cases when we're done. I'm not sure exactly what they'll look like yet, but maybe they start with an ambulance showing up and they hear an ambulance. It makes the students a little nervous. That's always a good thing, especially when it's not for real. And here's the patient. She might be saying, well, I'm kind of embarrassed. I think I've passed out. And the attending says, listen, there's a lot of possible questions, but which one of these is the best? Which one of these is going to help you to focus that differential diagnosis so that you know that you're on the right pathway to getting the right answer from the patient? Not the right answer from the patient, but the answer for the patient. And then once the student picks one of these, then they immediately get feedback. So imagine they picked the wrong answer. Well, what would happen is the simulation will come back and say, you know, that is a reasonable question, but it's not your best question. Your best question is going to be to focus that differential diagnosis. Go back and try again. And they keep trying until they pick on the right question. Once they do that, then it comes back and says, that's great, and that is the right question. And here's why it's the right question. And then they get the answer from the mocked patient, and then they go on in the simulation. And if done right, that means they can't, listen to this, they can't get through the simulation until they've learned the pathway that we're teaching them. They can't, there's no way through it except to get it right. It might look like this. I don't know exactly how all this is going to look yet. We are doing podcasts now. One of my colleagues, Dr. Sifu, and I have already started. We have one that's done for those students that like podcasts. I've done a series of online video lectures already. We did 122 for another project. We're now in the midst of updating them so they're as concise as possible to appeal to the students. We're working on mobile apps too so that when they're at the bedside, they can use tools. So one version of this we did with a company called Agile MD that we started at the university. And this might be a little hard for you to read, but it would be on a phone so they can make it bigger and smaller. And so here you could see they would start with, this is literally, imagine a giant interactive PDF on their phone. And it might say, okay, here's loss of consciousness. Your first step is to distinguish syncope from not. Here's how you do that. Which way did you end up? Okay, you ended on syncope. Your next step is to distinguish cardiac from reflex syncope, and so on. And at each step, it gives them the information that they need on history and physical and labs so they can proceed. When I show this to folks, unfortunately, a lot of folks don't like algorithms. I like algorithms. I'm very happy looking at an algorithm, but I might be the only one on the planet, I think, who likes algorithms a lot. So we're working on other technologies that would help them. One vision we have is the following. Imagine this is on your phone. So it's broken into problem statement, a differential, and tasks. So the problem statement evolves. That is, how do we state this problem as precisely and as accurately as possible as we get information? So remember we started with abdominal pain at one point, and abdominal pain had that whole list of possibilities. Now let's say the patient said, my pain's actually, you ask the patient, and they say it's in the right upper quadrant. The problem statement changes, and now the differential diagnosis, the list of possibilities, changes with it. So it evolves. They could follow breadcrumbs to see how it's evolved. They have a differential diagnosis, again, a list of possibilities. But that's going to evolve too, because as we ask them to get information, and as they enter that information, the list will change. And I'll show you an example of that. They could get more information about a particular disease if they wanted, and this is their current task that they should be doing. They should ask the patient in this particular example, was the loss of consciousness abrupt? Was it short in duration? Did they have a spontaneous recovery? They make their selections. Now they've made their selections, and what happens is all of this evolves. The problem statement changes, the differential diagnosis changes, and the task changes. And what they end up with now is a new problem statement, because it turns out, those of you that aren't medical, is that if you've lost consciousness and it was sudden in onset, and it was brief, it was only a minute or so, and you recovered on your own, that would define syncope rather than those other non-syncope causes. So we've changed the problem statement. We've changed the differential. Seizure's no longer on that. And now we've changed the task for the next step. So all of this is in process of being developed. All right, so there's also educational curriculum. How do we help schools to teach this better? How do we do that? So I want to tell you a little bit about what we do at the University of Chicago, because this is what we're going to try to work with schools all over the world, literally, to do. So at the University of Chicago, I told you we teach the course on disease, and it's broken into organ systems. So we have a whole week or 2 weeks on the heart. We have a whole week or 2 weeks on the lungs. We have a whole week or 2 weeks on the kidney. We go from disease to disease to disease to disease. And each half day is on a disease. At the end of that organ system, we can then give them symptom lectures about that organ. So for instance, we've just done cardiology. So they've learned about heart attacks. They've learned about heart failure. They've learned about diseases of the valves of the heart. Now let's give them a chest pain case and teach them about how to evaluate chest pain and see if they can figure it out. And we can do that for each of the organ systems, and we do. We also have a course that I run that's right before they go on the ward. So medical school, for those of you that aren't medical school in medicine, the way it works is the first 2 years are learning in the classroom, essentially. And after the first 2 years of learning in the classroom, students go on the wards to see patients. So after they've learned about diseases and just before they go on the wards, we have a transition course which teaches them all about symptoms. It's 7 days long, and each half day is a symptom, and it utilizes lectures and cases. And that looks like this. We don't have to be too boring about this, but we basically are handling many symptoms and giving them lectures and cases right before they need it, right when they want it. And the last part of this thread in the curriculum at the University of Chicago on diagnostic reasoning is actually when they're on the wards and they're in the medicine clerkship. And there we have lectures online. So I just told you we're recording these lectures. We do what's called a flipped classroom. They can look at the textbook. And then what they do is we have them engage in classroom discussion. So instead of me lecturing to them, I'll pretend to be the patient. And they have to figure out what's wrong with me. And they can ask me questions on history. They can ask me questions on physical. They can ask me about tests. And the beauty of, and I actually make it a competition to engage them. And they get points for asking good things, and they lose points for having the wrong diagnosis. But the beauty of that is I can watch them think. So if someone asks me a really great question, I can say to them, boy, that was really thoughtful. Why did you ask that? Explain to your other students why you've asked that. And if the question is off the mark, I don't say, well, you're a stupid fool. That was really a bad question. But I'll say to them, well, what did you hear before? And let's talk about whether that's useful or not. And they come to realize that actually they're off the mark in a way that's helpful to them. And the last part of this, the curriculum that's incredibly important, is I've already told you we have to test students on what we want them to know. If at the end of the day, all I do is go multiple choice questions to the students, all they're going to learn is those facts. And we learned this the hard way. So when we wrote our first edition of the book in 2002 and finished it in 2005, I was a very proud parent of a new book. And I thought all my students would walk around carrying it around, and I saw they weren't carrying it around, and I was getting all stressed out. And they were still carrying those stupid fact books around. I was ready to pull the hair out of my head. As a matter of fact, I think that's how I got the bald spot that I have. And I asked them, I said, why are you carrying, I'm telling you as your faculty member, this is what you need to know. Why are you studying the wrong book? And they said, because that's what you're going to test me on. You're going to give me an examination at the end of this clerkship, and it's going to test me on facts, and if I want to do well, that's what I need to study. So what we did is we changed the test. And educators everywhere actually know that you need to align your curriculum with your examination, otherwise you're going to fail. So those of you that don't know, these observed standardized clinical encounters are situations where doctors are faced with a standardized patient. It's an actor who acts like a patient. And we've scripted this out carefully, and we have a very careful scorecard, and we're watching in another room from a video. Are they asking the right questions? Are they doing the right physical exam? And after that, meeting with the students and saying, do you have the right differential diagnosis or not, the right list? And how would you test them? And scoring them. And now guess what they're studying? They're studying what we've told them to study because they know they need that to pass. So you might say that's using a club, but as an educator, you have to align your tests with what you want people to learn. I think this is the last part of our curriculum that we've innovated on, is what we call an urgent care elective. So one of the problems I mentioned already with doctors training students is we're really busy. So if a student comes with me to the urgent care clinic where we have lots and lots of sick patients, I have a limited amount of time to talk to them because I've got 30 patients to see that morning, right? So we've set up a different elective where the students are with me every morning in urgent care, but the key to making this succeed is I'm an extra attending. The regular attendings are already there, and I'm an extra, so I can take each one of those 3 students, have each one of them see 2 patients on their own, then they come and get me and I go in the room with them. They present that patient to me. These are real patients. We talk about it, we decide what to do, and then every afternoon we go over all those cases. What do we know? What don't we know? So this is case-based learning that's about real live patients with a faculty member who has enough time to do it. The challenging part of delivering this is having the funding to do it because it really requires that you're having another doctor in the clinic that you wouldn't normally have there. At the end of the day, the idea will be that we'll have a portal with all these different activities on it, and the students will be able to access whatever they want. They might want to look at the learning exercises, they might want to go to the quizzes, they might want to do all of it, but they can do it in the order they want. I know how I would tell them to do it. I'd say go to the lecture first, read the text next, do some cases, and then do your quizzes. But a lot of students like to go to quizzes first. I'm agnostic. Do what works for you. It's okay. So the way I just said, I don't know how they're going to use it, but they'll use it. Our partners in this whole project include a collaborative group of educators in the United States. We currently have international partners. We've been doing this, I've been working in Manipal, India now for over 5 years, and we've just started the Diagnostic Reasoning project there. We've worked for 5 years, or probably closer to 10 years now in Wuhan, and we're just starting Diagnostic Reasoning in Wuhan. And we hope to develop other partnerships. So I'm here in Hong Kong. We're hoping to develop partnerships so we can do this work here as well. In the end of the day, I want to get it beyond medical students. I want to get it to medical residents and anyone who's providing care for patients, whether they're nurses, doctors, residents, what have you. Everybody who's taking care of patients needs to know what they're doing. What a shock. So in summary, what I tell you is what I've already told you, right? That's the summary. Diagnostic error is a tremendous problem. I believe we have educational paradigms and technologies that can decrease diagnostic error. I think we have the potential to actually improve patient care on a global scale, and that we should develop regional centers of excellence. And so once we have those schools in different places that have adapted these approaches and their technologies, they can then serve as the core for their particular areas. And I think a non-for-profit center that develops these processes and makes it free is the optimal way to get this across and maximize impact without a profit motive. So with that, I'd love to open it up to discussions and questions. Thank you. Please.
I'm really impressed with your presentation.
Oh, thank you.
Thank you very much. One question.
Please.
What kind of technology do you think helped you the most to develop that algorithm?
To develop the algorithm?
Yeah.
So it's really a combination of, I don't know that it's a technology per se. I mean, all of us have done this work, have been in medicine for decades. And we take that fundamental knowledge and then we look at the literature, literally thousands of papers, to say what the data says. So as an example, gallstones develop in the gallbladder's in the upper part of the abdomen up here. So it's traditionally taught that if patients have gallstone disease and pain, that the pain's in the right upper quadrant. This is the right upper quadrant, right? The trouble is that if you actually look at the literature, that's not what the literature says. If you look at all the diseases on all the papers on gallstones, a third of the patients who have gallstone disease actually have pain in the middle of their belly. Well, if you know that from the data, then you have to include gallstone disease not only here, but here. So it's not so much a technology to apply to it as going through this literature carefully, methodically, and trying to put the information to get together in a rational way. It takes a lot of time. It's actually taken us almost 2 decades to get to the level that we're at. Sure. Welcome. Please.
I think what you have done has done a lot of good for the medical education, for medical students and then the future doctors. I'm a surgeon and I'm also a mediator. I tell people not to sue doctors. So in USA, we know that they sue doctors a lot, more
Yes.
than in Hong Kong. So I was just thinking when I was listening to you, to suggest to you that to make use of the first few slides and go to talk to the patients, the ordinary citizens, and not the medical school only, because that is equally important if they understand the difficulty of making a diagnosis.
Nice.
And they probably will forgive the doctor for not making the diagnosis, the right diagnosis, correct diagnosis at the beginning.
Right.
And that would be less lawsuits.
I think that's probably true. I think the other thing that contributes to lawsuits is when doctors don't have enough time to spend with their patients. You know, if patients know that you care about them, no one's perfect. And I defy any doctor who's in the room to say they've never made a mistake. And I've made mistakes. And when they're significant, I've gone to the patients and said, that was wrong. But the patients who I've cared for a long time know that we're working hard to do the best that we can. And almost uniformly, the response has been, that's okay, let's just keep moving forward. But I think you're right. It'd be interesting to get this information out to the public. This is a difficult job. Thank you. Questions, thoughts? Please.
Has there been any research or thought into psychiatric diagnosis? Because I would argue in the realm of psychiatry and psychology, a lot of the mental illnesses actually present themselves as more comorbid as opposed to internal medicine diagnoses.
Right, so I'm an internist by training, and all of our work has been focused on internal medicine. What I'd love to see happen as this pathway and these processes go on is they extend themselves to other fields. So we're not covering pediatrics right now. We're not covering psychiatry. We're not covering obstetrics and gynecology. What should happen over time is that we have colleagues in other areas who have that expertise and can develop. As a matter of fact, I met with somebody just before I came over from obstetrics and gynecology at the University of Chicago, and they were very interested in what we were doing in medicine and trying to learn from us about how they could try to develop similar approaches. You're absolutely right, but it's true for all the big primary care areas, whether you're talking about obstetrics, gynecology, pediatrics, neurology, emergency medicine. A lot of the work that we do actually covers emergency medicine, internal medicine, neurology, not psychiatry so much, but we need it extended in other fields. But I need somebody else with the expertise to do it. So if you are that person or you know of people to do it, that would be what we would need. Please.
Your emphasis is on the doctor's side.
Yes.
Is there any idea, say, how about on the patient's side?
Yes.
Because often the wrong diagnosis is from the questions from the doctor. They ask the wrong question.
Right.
I give you the wrong answer.
Right.
Or I give you the right answer. So
I understand.
Yeah, so it may be on the patient's side.
Right, we've been talking about this for the last 36 hours because everybody's asked me this question actually. It's a really good question. You know, I've been naive over the years and I've thought it would be easier than it's been to train doctors. It's hard to actually change systems and to change doctors, and I actually think that you're right. And the question is, how do we do this well? And at the last meeting I was at, one of the ideas that came out of that would be, I should not create an app that tries to tell you what you have, because that's very difficult. I'm not seeing you, I'm not sitting with you, I don't know. But what I could tell you in an app is if you have a symptom, here are the things that you should think about. Like, do you have, let me give you an example, it'll be easier. If you have chest pain, it really matters whether it comes on when you're walking. And it really matters whether it came on after you eat. Because if it comes on after you eat, it's normally some form of indigestion. And if it comes on when you're walking, it's probably heart disease. And for every symptom, there's a series of questions that will be really useful if you have them to tell your doctor, right? So could I give you, sorry, one second. Could I give you the questions to you, the patient, so that you say, wow, that's what they said I should tell them if I have this, so that you go to your clinic appointment well prepared.
One question, very simple. Because you asked me to have a chest pain.
Right.
And then you asked me, describe it.
Right.
I don't know how to describe it. I just have paid.
Right,
So
but-
you must give me some,
Yes.
some guidance.
So
What's the
that's
pain?
exactly what I'm saying the same thing to you. So I'm not just asking you to describe it. Well, the first thing we do is we do ask you to describe it. But a good doctor then knows the other questions to ask. So what if I gave those questions to you? What if online you could say, you were told on this online thing to say, does your pain occur when you walk around? Or does it occur after you eat? Or does it occur when you take a deep breath? If any of those are true, make sure you tell your doctor that, because those are all key pieces of information. And if they didn't think to ask you it, you telling them that could be very useful, because each one of those possibilities will really point to different diagnoses.
That's the difficulty from the point of view of the patient. They don't know how much they should talk to you.
I understand, and there's cultural issues and all sorts of things. But what I'm asking you, kind of, if you saw on an online app that telling your doctor that you have chest pain when you walk around will give them a lot of information, would that empower you to make sure that you say to the doctor, look, I'm having chest pain, and I need to tell you it's a lot worse when I walk, because you've read that that's important? Would that be helpful? It would be helpful to the doctor, and I think it would be helpful to patients.
I mean, if there was like a decision tree, and then what are for the major traumas or whatever that are out there,
Right.
what does it start with? What's the first thing that you focus on, and then branch out, branch
Right.
out? You could do that while you're waiting for the doctor.
Absolutely, right. And maybe it's not exactly a decision tree, because I think there's difficulties with a patient coming in and saying, I think I have pulmonary embolism. Right, right, right. But what they could say is, I'm short of breath, and it's worse when I take a deep breath, and my leg is swollen, and all of those are important pieces of information you should know, because doctors are actually pretty good. If you tell them the right story, they often know what's wrong with you, but they not thoughtful enough to ask the right questions. But if the patient had the right questions already answered, and they went preloaded with that, it could be helpful.
I had a friend who, unfortunately, was hit by a tree in Hong Kong a couple of weeks ago.
Hit by,
He
okay.
just fall down here.
Yeah, okay.
Literally. Waiting for a taxi.
Okay.
Fell on him. It hit his right shoulder.
Okay.
It hit his head. He's all over. But we saw in the trauma unit several doctors come through in the first few hours. They were all asking completely different questions for the same person.
Right.
It's like, I don't know if we're getting good treatment here or not. Right?
Right. Well, who knows?
But anyway, if you have this app, if the hospital handed it to you and said,
Right.
here's an iPad, go through this.
Well, I will tell you what's happening at the hospital level. One of the, I mentioned that we started a company at the University of Chicago called Agile IMD. And what Agile has done is pivoted to try to put the questions into the electronic medical record. So what happens for the hospitals that are using this now is that as a doctor starts to, do you all have an electronic medical record in Hong Kong?
Yes.
Yes? So as the doctor starts to enter the note and a person has a problem, information starts to come up that guides the doctor. And the reason that the doctors will use this is because it makes them more efficient. As they click things, it makes their note. As they click things, it places their orders. If you want doctors to use something, you need to make it efficient. If it slows them down, you can forget it. Yes, please.
Hi, Dr. Stern. I'm a medical student here
Hi.
at Hong Kong U.
Nice to meet you.
So I agree with you that if I had to learn all the atypical presentations, my head would explode. So I was wondering, in your teaching tools, how do you delineate for medical students or for medical residents who use it, how do you delineate between classical presentations and the atypical presentations, and whether or not you automatically include them in the list of questions you need to ask, or if you make it clear that these are atypical?
So what I do typically, because the term we have for when there's too much information is cognitive overload, right? And you've probably faced cognitive overload in the last couple of years, I would bet you. So what we typically do is we describe mostly the classical presentations. But what I want my residents and my students to know is to have a sense of humility that it's not often like that. So what I tell them is when you're seeing a patient and a particular disease is on your list, like pulmonary embolism, and the patient doesn't have all the classic findings, instead of scratching that off your list, you just make it lower. And you don't actually know the disease. So they're tempted to say, I'm sure it's not pulmonary embolism, I'm sure it's not X, I'm sure it's not Y. You know it's not X, and you know it's not Y when you know what they have. Until you know what they have, those possibilities are still on the list because people present in weird ways. So you use that information to rank it, but you don't take it off. That's why I grayed out seizure and I didn't cross it off. Please.
I think I understand what this gentleman was talking about.
Yes.
When he said, as a patient, how do I know which answer to tell you?
Right.
Like, how do I know that my ankle swollen is important
Right.
to you?
Right.
So, but to reassure the non-medical audience here, we do teach medical students how to ask questions in medical schools, and I'm sure Professor Cindy Lam has done a lot of those teaching, and she is doing a good job. So perhaps she is the better person to tell you, or tell the gentleman how we train our medical students to ask questions. We don't just rely on, tell me what you know. We don't say that.
Do you want to expound, Dr.
Sure, okay. I mean, first, thank you very much for this
Sure, you're
for
welcome.
very enlightening lecture, and I think is really opening up of like how we should be rethinking the clinical reasoning, okay, which sometimes we don't do enough. I mean, theoretically, we teach all our medical students, doctors to do that, but then when one is pressed for time, medical students, when you're pressed for answers by your teacher, so you just think of anything that comes up to your mind. So what we really want to do is to really make it a habit, and I really like your training course. So it's so ingrained, like in the thinking, the way of thinking when you're actually approaching a patient. So you really have to do it again and again and again and again, and really like your large number of symptoms. So they really go through that habit of doing it. So the question that I want to ask is, how long does it take? And of course, curriculum time is always precious. So if I would like to introduce into my
Right.
curriculum. So
What would be the shortest
Yeah.
time?
well, I mean, maybe the longest time. Okay, so what should I go to my dean to actually, as a professor, to say, okay, this is what we're going to do, and this is the time, and then of course resources.
So I would say for medicine, the course that is most focused on this that we deliver is the Foundations in Clinical Medicine elective that we have. And I would think if we had roughly 2 weeks, we could do that pretty well. It's best if we keep coming back to it. It's not ideal if one person teaches it and then they never hear about it again. It's best if we teach it in that course and then some of the medicine faculty learn to encourage the same sort of approaches and test the same sort of approaches, because the more students come back to it with all they have to learn, right, the more things are repeated, the better off you are. But I would think an elective of 2 weeks length would make a big dent in it.
That's very doable, and especially I think when you've got this app as a support and additional learning resources for the students, so they can really go through that again and again. And when if you have a broad enough range of symptoms, then they can always go back, okay, you see a patient like this, and then they can go and then go through that exercise and
Right.
the algorithm. And I think this will be really very, very helpful. And I'm really looking forward to learning more from you, and also to actually see your
The products.
Product. So what's the timeline?
The time. Okay, so I'm glad you all came tonight. No, the timeline, what we've promised the Marcus Foundation is that we would have the entire project complete in 4 years. But we're not going to wait to roll it out for 4 years. As things get done, we will roll them out. And we're hoping to make that faster, but that's the timeline that we've committed to. Actually, I think the reality is it'll continue to grow and grow and grow past 4 years if we're successful. But that's when we would be committed to having all the symptoms done that I mentioned, all the diseases done, and all those technologies done that I've mentioned. I'd like it faster,
Yeah,
but
looking forward to it.
thanks.
Sorry, what sort of feedback have you gotten from clinicians who have undergone this social training, or even patients who have come in, and have they seen a shift in the bedside manner of the clinicians that they do deal with?
So first, feedback. I would say that feedback from the students is great, because I think students appreciate that they don't take this wrong. They don't know what they're doing yet, right? It's a struggle. Medicine is complicated. And when you're in the clinical arena and you don't know what you're doing, you hate it. As a matter of fact, you want to hear a funny story? So I teach the course on disease. And one day I'm up there teaching, and I was at the University of Chicago as a medical student in the early 1980s and took this same course in 1982, you know, before several of you were even on the planet, right? So one day I'm in the lab walking around, and I see the old lab manuals from back in the 80s. And I said, wouldn't it be interesting if I could see the lab manual from the year I took it to see what I was taught then and how different it is than now? So I took the lab manual out and I'm looking at it, and I realized that the back of the lab manual are not only are the evaluations of the course from the students, which meant my evaluation of the course from 1982 was in there, and it was handwritten. So guess what? I know which one is mine. It's not signed, but I know my handwriting, right? So I go looking for it and I find my evaluation. I say, the course is great, I've learned all about diseases, but I have no idea how to handle a problem, and maybe you should give people algorithms. And I wrote an algorithm, and the algorithm was completely wrong, but the idea was right. So I think students are eager to have an approach that they can put in their heads, and I will tell you, when we try to design these algorithms, it's really meant for something that you can put in your head. It's not meant to be IBM Watson solving this, right? So I think the students are eager for it. I think if you look at clinicians who've been practicing for a long time, this isn't going to be helpful to them. If you took me just as a practicing clinician and you say you have to use system 2 thinking all the time when my system 1 thinking works well because I've been at this for 25 years, I'm not terribly interested. So I think the student feedback has been great, and I think the patients don't really know. You know, all this goes on behind the doors. They don't know how we're being trained and what's going on and things of that sort. Yes, please.
Hi, sorry, second question.
That's okay. You're allowed.
So I think for medical students, all of us can end up with a list of differential diagnoses, but oftentimes it happens by just asking patients just a lot of questions, and
Right.
we're taught to organize it afterwards
Right.
into a very kind of in a medical way
Right.
that paints a clinical picture.
Right.
So I was wondering, and like you said, the exams matter a lot, and in our exams, it's often that we take the history and then we go present it to the doctor who then grades us on our presentation. So they miss the question asking bit, and we're not really evaluated on the order of the questions that we ask. So I was wondering, in your OSCEs, how do you objectively evaluate
Sure.
the order of questions that students
So
ask?
we don't actually penalize people for having the wrong order, but we make sure that the right questions are there. So a student has, the way the OSCE works is a student's in the room with a standardized actor for 15 minutes. We are in another room with a video recorder and a score sheet. And so if we had abdominal pain, I'd be listening carefully to make sure you asked the patient where their pain was. If we had loss of consciousness, I'd be careful to be listening. Did you ask them, was it sudden in onset? How long did it last? What do you remember? And so I've got score sheets for all that. So I'm watching and checking all of that so that it's objective, and you can't say to me, well, Dr. Stern didn't like me and he didn't give me a fair grade, right? Then we watch you do a physical exam. Then you come out and talk to us for 15 minutes. And when you come out and talk to me for 15 minutes, I'm going to ask you, first give me a 2-liner description of the patient, and then tell me what you're thinking about. What's your differential diagnosis? How have you organized that? You know, how are you going to proceed with testing? So all of that's objectified. Haven't you seen, those of you that are, how many of you are medical students in the room? So how many of you have seen, you've asked the patients 100 questions, and the attending goes in and then asks 2 questions that you wish, boy, I wish I'd asked that question. Does that ever happen to any of you? I don't see much for nods. Does that happen to you? Because they've learned what the processes are. They know how to focus. So you've asked 10 times more questions, but they get the right questions. Other questions? Yeah, please.
Okay, I'm a medical student as well, and I agree with you that we often tailor our study methods to the way we examine. So I myself tailor my methods based on
Sure.
the way examine. The fact is, the way we examine in HKU is on a third is fact-based, and a third is hospital. And you just mentioned that fact-based exam, that multiple choice is very good because it doesn't stimulate what the doctor needs to know. So, as someone who's taught medicine for so long, what do you think the place of multiple choice questions and sort of fact-based tests should be? Should we get rid of it completely, or should we reduce its percentage of
Right.
should
Right.
OSCE take a more dominant role from like earlier times? Like, what do you think the ideal sort of examination processes for medical students should be in the future?
So that's a really good question. I've been trying to provoke you for the last hour, and I think I've succeeded. So, of course, we need to know that you guys know the facts. If you don't know the facts, you can't operate, right? You're absolutely right. I've kind of been extreme, right? Because I've been extreme because I don't think we've evaluated processes very well. So the reality is we do need to do both. The trouble is, and I'm provoked by this in the United States, is many of the very high stakes examinations that students spend a lot of time studying for are multiple choice questionnaires. In the United States, students have to sit for licensing examinations, and those licensing examinations determine what residencies they can have, right? So if you want to go to a competitive residency, you better do really well on those multiple choice questions, and they will sacrifice a lot to just do that. So there has to be a balance, right? And when the OSCEs are built, they also have to make sure that they're really studying approaches rather than just more. OSCEs shouldn't be just another way of asking more questions about facts. You know, if the patient in the OSCE says, I've had a pulmonary embolism, and the question is, how do you manage that patient? That's not helping very much, right? So I think we have to define very well, what is the process I want you to learn, right? And then use the OSCE to evaluate that. And the answer is, we need to do both that and the multiple choice question. I don't know that I have the right answer for what percentage, but you need to know both pieces of information. But your point's well taken.
Thank you.
Sure.
Last question. 3, 2, 1. So let's give a big applause to Dr.